All right, this one is a pretty rare finding. I actually showed this at our conference recently. This is something you don't see a scan of very often because when it happens, it is an acute disaster. But this is left ventricular rupture due to an acute MI. So it's right there. There's this little wisp of contrast that on the cine you'll better be able to appreciate, but there's just this tiny thin slit of contrast exiting the left ventricle and causing a pretty significant hemopericardium. So this happens usually 48, 72 hours after an acute MI, which is another reason you don't always see these on scan, right? These patients don't present acutely with rupture. They typically present with a heart attack, and then it ruptures while they're being monitored in the ICU 48, 72 hours later. And if they're on steroids for any reason, that worsens their risk for this. So I actually saw one of these live, and look at the hemopericardium, right? You see how hyperdense it is, even with the windowing as it is, which I did to better show the actual contrast passing through the ventricle there. Right, but even with that windowing, you can tell that that pericardial fluid collection is too dense. It's on the order of muscle rather than fluid. And look at that wisp of contrast there inferiorly in the pericardium. So yeah, I saw a case of this. I was on call as a senior resident in the CCU, and we had this guy who was on really high dose steroids for his lousy COPD. And it was a question of when rather than if he would rupture. And of course, he chose my night to rupture. And I always remember it was just like that aortic dissection case where his heart rate shot up to 200, his blood pressure plummets to 60, and he was sitting upright, gripping the bed rails, just screaming in the worst pain I've ever heard anyone be in. This was not this particular case, but it's exactly the same thing. And I remember I turned to the nurse and said, give him 10 of IV morphine. And she didn't even balk because I was looking at him and just thought, you know, we got to get the bypass team up here and the thoracic surgery team mobilized, and it's 2 a.m. and there is no way we're getting on top of this. And so I had the nurse give him 10 of IV morphine, and he uttered the most memorable of all last words I've heard. He looked at me and he said, "Whew, doc, you really know your shit." And then he died. So yeah, it's almost always an acute mortality event.
Dr. Strong, quick question on that last case. There was a hyperdensity in the esophagus. Was that just an incidental finding, like oral contrast, or?
Yeah, most likely. Yeah, he just had a little dot. Don't know why that is. Yeah, it might have even been some Pepto-Bismol for that matter. But yeah, it doesn't look like he got oral contrast. So yeah, remember iron formulations, Pepto-Bismol. There are other things that can give you density in there. This guy should have been NPO, but he was a pretty acute presentation. So he had let his heart attack go on for some time, which is why we were CTing someone with acute rupture. So I don't know what he got there, but I don't make much of that. You know, every once in a while, and we may see it today, you can develop aortoesophageal fistulae. And so it's good to note when there's density in there, but I think in that case, it probably didn't mean much. Good eye, though. All right, so I actually, in lecturing recently at a conference, I asked for a show of hands. I said, how many of you have ever seen an endocarditis vegetation on CT? And not a single hand in the room went up, which I thought entertaining because I was looking on the NCBI, the National Center for Biometric Information. If you guys remember that trauma study I have, I put the mortalities of all these conditions up. And so the NCBI is a great source. And I looked up the sensitivity of CT for endocarditis, and it was like 90%. But it didn't cite any other particulars, like what are the findings you can expect to see. And I thought, man, I've been looking my whole career for an endocarditis vegetation on CT, and I had at that point like one. And so I thought, I don't know what they're basing that sensitivity on. It must be the downstream findings, but I thought that was very interesting that they would cite such a high sensitivity. CT is not great for endocarditis, especially for direct visualization of vegetations. So don't count on it at all. However, with that caveat, I'm going to show you 3 now that have visible endocarditis vegetations. But it's the secondary findings that I think you really need to be tuned to, and that will direct you to the diagnosis of endocarditis. And I think it's got to be what that relatively high sensitivity of CT for endocarditis is based on. All right, so this is fairly unusual with septic emboli. We've seen a few cases of septic emboli, and you usually don't actually see the physical filling defect in the pulmonary arteries, right? What you see are cavitary lesions, usually in the periphery of the lungs or lobes, and with relatively shaggy, infectious-looking walls, right? But this is an exception to that. There is a huge filling defect in the right PA here. And then on the lung windows, you can see he's actually got a combination of septic emboli with little cavities forming and wedge-shaped defects suggesting pulmonary infarcts. And there is the vegetation. When you see a tricuspid valve endocarditis, it's almost certainly IV drug use, and it often is associated with significant right atrial enlargement. The tricuspid valve is really pretty bad at its job anyway. It's always regurgitant. When you start looking at echo reports, you'll see almost every single echo that comes in reports 1+ tricuspid regurg. And I used to bet people, I'd say, who wants to bet a Coke on whether they give it 1+ or 2+ tricuspid regurg? Because it was always present. It's just the question is to what degree. So with the tricuspid not being that competent physiologically, when it gets infected, it really becomes incompetent. And so right atrial enlargement with tricuspid endocarditis is a pretty common finding. So there is that huge filling defect, again, very unusual for septic emboli. But that is a classic setup for septic embolization where you've got right tricuspid endocarditis. Obviously, that's right in line. And look at the thickening of the chordae tendinii, so that vegetation isn't just involving the valve cusps, it's actually running down the cords as well. All right, and here is his lung windows. And you see it's a kind of a curious combination of small cavitary lesions that are mostly peripheral, and then these wedge-shaped things which denote pulmonary infarcts. All right, this one is a mitral valve endocarditis. This was related to a line infection, so you can see a fibrin sheath there around a line that may or may not still be present. I think it is still present, but remember, you can get those fibrin sheaths and they'll persist. Even after they pull the line out, there will still be a linear filling defect there because those fibrin sheaths don't just resolve upon removal of a line. And there you can see the thickening of the mitral valve right there. And that's the endocarditis vegetation sitting on it. And this patient had recirculating, obviously the mitral valve vegetation was not directly responsible for these septic emboli. But most people with endocarditis have a persistent bacteremic state. That's how their valves get seeded. And usually it begins as a septic thrombophlebitis. So that was the case here. Obviously, we had a line infection. And so this patient was at risk still for septic emboly, even though it's not directly referable to that mitral valve vegetation. And there's a significant pericardial fluid collection, which in the setting of endocarditis, you're going to want to call a pyopericardium. Ugh. Nice septic emboly there right up against the fissure, right in the periphery of a lobe, and some early cavitary lesions on the right as well. Nice one out there. All right, this may be my favorite of the endocarditis cases. So this one does not have an actual visible vegetation, but again, secondary findings are what are going to lead you to to surmise that this is endocarditis. And this is the best one of those secondary findings. You see that little contrast collection right in the highest part of the septum, immediately adjacent to the aortic valve ring. That's what's known as a valve ring abscess. Okay, that's where aortic endocarditis will burrow into the top of the muscular septum. And we've got a pericardial fluid collection, which again, we're going to call a pyopericardium, just given the setting. So this one, I remember the radiologist that sent me this case said it was the case that just kept giving. There are infarcts of all the major organs, and again, secondary findings that would lead you to the conclusion that this is endocarditis, right? So there are renal, splenic, and even a hepatic infarct, which in the arterial infarcts, they're much less common, obviously, in the liver, but they do happen, and they look just the same as embolic infarcts elsewhere, in that they're subcapsular wedge-shaped hypodensities, well circumscribed for that matter as well. All right, so this is another favorite pimp question of mine. Valve ring abscesses present with a particular complication. And it's, well, I won't say any more. Anybody know the particular complication that's associated with valve ring abscesses of the aortic valve? Nobody ever gets it. But it was a common internist pimp question. They used to always love to ask these at grand rounds. The answer is heart block, because that abscess is burrowing right into the location of the AV node. So they will present with heart block and a dissociation of atrial and ventricular contraction because of the exact location of that valve ring abscess. So you can see it's kind of on the anterior side on the coronals. And there we get another view of all the organ infarcts.